Okay, right into auscultation. So this is our main point of the lesson this week, and yeah, there I am. So auscultation is the action of listening to sounds from the heart, lungs, or other organs, typically with a stethoscope as part of a medical diagnosis. So for us, we're not really doing it as part of a diagnosis, but we are doing it as part of our assessment to help determine what we can do to help these patients. So that is the definition. Auscultation tips. Now, these are things that I've just kind of put together that are important to me when I'm doing clinical precepting or when I'm doing a pulmonary assessment on a patient. These are some things that I think are important, and I kind of have compiled this little bit of list over the years. We want to instruct our patient to take slow, deep breaths. Super important. You want them to take in a slow, deep breath, and a lot of times I'll say, breathe in through your nose, out through your mouth. Start to listen near the bottom to detect atelectasis. So if you're waking your patient up or you're doing a assessment first thing in the morning and you start to listen near the bottom, you'll understand in about 10 minutes why that's important and what atelectasis sounds like, what breath sounds we hear, and why that's important. Listen from side to side at the equivalent site. So the big thing that I teach and I want you guys to think about is, are the breath sounds equal and bilateral? So one down here, note if the breath sounds are equal and bilateral. Well, if you listen from side to side at the equivalent sites, you'll have a much better chance of knowing if you are indeed, if they are equal and bilateral. So listen from side to side at the equivalent site. So if you start anteriorly, mid-clavicular, and you're listening at the top anteriorly, you want to listen at the top on the right side and then move to the top on the left side. You want to listen for one full inspiratory and expiratory cycle. If you move your stethoscope too quickly, a lot of times you will miss late phase expiratory wheeze, or you'll miss something if you move your stethoscope too soon. I had a student at one point listening to breath sounds, and I listened after the student did, and when asked what they heard, the answer was just diminished. And what I heard was a late phase expiratory wheeze. And we'll get into that when we talk about COPD patients and wheezing, kind of how the physiology manifestation of that is such that they can have a longer expiratory phase, and then you can hear, if you're not patient and listen for the full inspiration and full expiration, you may miss an adventitious breath sound. Don't make the patient hyperventilate. That's super important. You just want them to take a slow, deep breath, but not so deep that they're hyperventilating by the time you're done listening to all your auscultation sites. Note if the breath sounds are equal and bilateral. This probably should be up on the top of the list because that's the most important to me, and that's why we listen from side to side at equivalent sites, so we can listen if we've got equal airflow on the left side versus equal airflow on the right in that same area of the lung. Know the thoracic landmarks that coincide with what lobe of the lung, and we just had a whole video on how to do that, so we're good to go there. So those are kind of some auscultation tips, and I will definitely quiz you on one or four of those next week, so you can guarantee that will be something that is important to me, so I want it to be important to you, so this will be on the quiz. This is the suggested order for auscultation right out of the Egan's book. And if you listen to the nurse video that I put, the YouTube video of the nurse that does the auscultation assessment, she says to start at the top, and this says to start at the bottom. And realistically, the reason we're starting at the bottom is to identify those sounds where the patient may have been laying on their back, and so they may have had some dependent edema. They may have had something where the alveoli have collapsed, called atelectasis, and then if that's the case and we hear crackles, we need to know if they're there originally. and we need to know if they stay there. So it's compared to the video. Starting at the lung base may identify benign crackles that disappear with a few deep breaths. So you may hear crackles when you start listening. So where they want you to start listening is here. So what do we know this area of the lung is? Yes, we know that's the right. And over in this corner, that's the only little place over there. That's the right lower lobe, left lower lobe. So how we're listening is the equivalent site on each side, right? So we're starting at the base and we're listening here. So first listen, inhalation, exhalation. Second, inhalation, exhalation. Third, fourth, fifth, and sixth. So anteriorly, at least 6 sites. So that's what we want to listen to anteriorly. Posteriorly, again, we're starting at the bases to see if we have these benign crackles. So 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. So you can see that the majority of this is going to be our lower lobes, but also some of our upper lobes posteriorly. So when you're auscultating, if you hear adventitious sounds, you'll know anatomically where to chart where you heard that. So if I hear crackles over here, I know that I've got, I can say that I have inspiratory crackles in my right lower lobe posteriorly. So when you're giving a report, you can report that as to where you heard it, okay? Here is mid-axillary, 1, 2, 3, 4, and you know what lobes of the lungs we're listening to here as well. So this is kind of a suggested order for auscultation. Now keep in mind, if you're going to have somebody, if you're going to listen to all of these sites, right? Okay, this is 10 deep breaths, this is 6 deep breaths. So even if you only listen posteriorly and anteriorly, the patient is still taking 16 deep breaths. And so you have to keep in mind that you don't want them to necessarily hyperventilate, because you also have to listen mid-axillary. So realistically, instead of having our patient taking, 20 plus deep breaths, we do have to listen, and we kind of talk about here in a second, like the minimum requirements for auscultation sites. So this is essentially what the book says that we want you to do. Go back to the lung base at the end, may identify if the crackles have disappeared. If they disappear, they were benign, not significant. If the crackles are still there after a few deep breaths, they are significant, okay? So normal breath sounds. Someone just called me normal. I've never been so insulted in my entire life, and that's me, 100% right there. Normal breath sounds, if you think about the size of the airways where you're auscultating, the trachea, we talked about that with the anatomy section, it's bigger, more airflow through there, of course, and so it's going to be a little bit louder over the trachea. Vesicular and the lung periphery as they filter through the airways and lung tissue. So air-filled lungs filter sound, solidified consolidated lungs transmit sound. You will also see terms like bronchial, bronchiovesicular in the literature. The majority of that is just normal breath sounds. So if you listen to your neighbor, which I guess we're not supposed to do that this year. So if you listen to a family member and they don't have asthma or underlying lung disease or something going on with the smoke, I don't know if anybody has normal breath sounds right now, but it should be just normal air movement in and out of the lungs. You shouldn't hear any adventitious sounds. So we can click on this and listen. And you guys will have this PowerPoint, so I hope that it works on there, that you guys can listen to those. Okay, back to our PowerPoint. I think I gotta shut this down, or I think it goes all kinds of crazy. Okay, so those are normal breath sounds, just in and out. So you put your stethoscope on those sites on the chest, and you listen for a full inspiratory and expiratory cycle, and then you listen equal and bilaterally, okay? This is a chest x-ray that you would see that would be associated with normal breath sounds, so nothing crazy. And we're going to go over imaging on week 4, so this isn't anything I want you guys to get really worried about. I just kind of wanted to give you guys an idea of what normal breath sounds were what you would hear, and you need to practice on everybody that you can get within 6 feet of, because it's really important to know normal. So when you hear something else, you know it's not normal, because that's essentially our job, is to figure out why our patient has adventitious breath sounds, what's not normal. So that's kind of our plan for this auscultation section, is to distinguish between normal and adventitious